I think what would be useful for us is if we can put them in 3 buckets. Patients who are progressing well, and we need to just go over the discharge instructions with them, congratulate them for being compliant and trying to achieve lifestyle modifications. But then we'll just come back and see them on a regular basis and encourage them to follow up with the CHF clinic or their cardiologist as indicated. So that's one bucket. So essentially we don't need to do anything with them other than reinforce good behavior. The next bucket is for whatever reason they're not progressing well. They have some symptoms, additional symptoms, and we may need to do something. Maybe it's increase their Lasix, or maybe it is give them doses of IV Lasix, but they stay at home. We may want to get them seen sooner in clinic, or we may want to come back the next day. And then another bucket would be, oh wow, these patients are now really getting worse and need to go to the emergency department. I think in general we want to avoid that, and I think I can say this pretty easily since I am an ER doctor. Their chances of being admitted with this chronic condition go up dramatically as soon as they walk through the doors. So to the extent that we can keep them out of the ER, I think is probably a good thing for them and everybody. Can you help us? What types of symptoms would we see to help put those patients in those 3 different buckets?
So the main issue here is the life of this patient acutely at risk? I think that's the answer that you need to come up with. Okay. If the patient is having severe shortness of breath at rest and he cannot lie flat, unfortunately, you could try an IV Lasix shot and see how they respond, or you could give a higher dose of a combination of diuretics. And, if they are hypertensive, you may want to bring the blood pressure down and observe them and come backwards. But if you feel like their life is at risk because they may develop, an acute respiratory failure from pulmonary edema, then you don't have that much of an option. So for those patients, you don't have that much of an option.
The patients that we walk in and our 911 sense goes off and says, we need to put you on CPAP and start throwing nitrates at you. Those patients, I think, those are actually the easy ones.
Yeah, that patient you're not going to. Now you have to listen to the patient too, because you may see respiratory distress in a patient, but he's comfortable with it because he's living chronically with some degree of respiratory distress. So don't go only for what you see. I mean, you gotta interrogate the patient and see how they're feeling. And the patients with chronic heart failure oftentimes have a good sense of when things are not looking good for them. If it's a new patient with a new diagnosis, it's very hard because there is anxiety and
Sure.
They are fearful and they may not be able to manage it properly. But the JVP, the lower extremity edema, gaining weight, those things can wait. They're not going to die because they have an elevated JVP. They're not going to die because they develop ascites. But if you're seeing orthopnea, I would say orthopnea. If you're seeing, PND, you may be able to wait because it's, a lesser degree of the orthopnea. But if you're having significant shortness of breath at rest or you're having orthopnea, then you're looking into having them evaluated in the emergency.
And that is for patients who don't always have orthopnea.
Correct.
Yeah, okay.
Correct.
So a substantial change. What about the patients that we want to put, so the 2 extremes, like with most things in medicine, the extremes are usually the easy thing. It's the ones in between that are difficult. What types of patients, so the ones in between, you mentioned, so if they have signs of just peripheral edema, we can work on that. Maybe do some things, but they don't need to go anywhere. It's really located in here. So if this is an acute life threat, we have to do something. Short of that, we have some time. So I think that's useful.
You could play with, if you have access to their electrolytes and to their kidney function, because if somebody has a creatinine of 2.5 and they are, having some orthopnea, you know that you're not going to be able to manage this in the outpatient setting. Okay. Because they may not respond to the diuretics, as simple as that. And, you're going to be wasting your time there.
I like that. So we see a patient who is, say they've gained 10 pounds, 8 pounds over the past 3 days. So that's certainly more than 3 pounds a day. See, my Aggie math. Let's say it's more than 3 pounds a day.
Nine pounds.
There you go. And they are having definitely increased peripheral edema. That's very concerning to them, but their breathing isn't a whole lot worse than usual. Maybe instead of being able to go 20 feet, they can only go 15 feet. But no orthopnea, no hypoxia. You say, okay, I think we can handle this by maybe getting some extra fluid off.
Correct.
You do a creatinine, and the creatinine is less than, let's just say that they are on, they're on 100 of metoprolol and 10 of lisinopril, and we think that that's pretty good. We're just going to leave that. But they're on 40 BID of Lasix. Mm-hmm. So you do an E group, and their creatinine is 1.4. Mm-hmm. For those symptoms, what do you think we should do?
So,
what would you recommend?
If the blood pressure is normal or high, my first step is going to be to double that diuretic. So if they were taking 40 BID, I would probably say, well, let's take 80 BID for the next 3 days. But again, at that level, you're probably going to say, take 40 milliequivalents of potassium daily, too, and we're going to check both the kidney function and the potassium 3 days down the line after we have made your diuresis.
So how rapidly would, say you go from 40 BID to 80 BID, and they're not on potassium, and normal functioning kidneys, how rapidly would you expect them to get to the point where, assuming they start with a normal, their K is 4,
yeah.
How 4.5, somewhere in there, how quickly would you expect to see them get low?
So you're going to deplete their potassium immediately, but you're not going to see it in the bloodstream until a couple of days. But okay. You're going to be depleting potassium from the muscles, potassium from the organs. So the replacement should start immediately, because when you wait for the low potassium level in the bloodstream, it's because all the intracellular potassium has been diminished too. So I do not wait 2 days to initiate the potassium. I do not wait for hypokalemia to be manifested to initiate the potassium when I'm at this dose of diuretics. The exception to the rule would be renal dysfunction, in which we need the guess is harder.
Right.
But as a good rule of thumb is for every 80 milligrams of Lasix, you should probably be thinking between 20 and 40 milliequivalents of potassium a day. So if you're at this stage, you are in 80 BID, so you're talking of 160, I would give at least 40 milliequivalents of potassium and check in 3 days, and it may be that you need 40 BID. Okay. But I think rule of thumb, if you're getting more than 80 of potassium of furosemide, you probably need some potassium supplementation.
When would you escalate, again, middle bucket, not an extremis, when would you escalate to IV Lasix?
Well, if let's say 3 days pass and they didn't diurese, so you have two options. You may add Seroxolin, to see if in combination with the loop diuretic will have an effect, or you could change the Lasix to Bumex and see the equivalent dose of Bumex and see what happened. And if the patient only is having lower extremity edema and is stable and is not gaining weight, then you may wait 2 or 3 days more and see and reassess. Again, as far as you're not having, significant hypokalemia or hyperkalemia that needs to be managed, or you're not having significant shortness of breath, you could play with this patient for weeks before taking him to the emergency department. So first step, increase the dose of the diuretic. Second step, combine diuretics or change the diuretics. Third step, you should be thinking in IV diuretics. And then if they are hypertensive all along, I probably will play with the beta blocker first, so I don't mess the potassium with the ACE inhibitor. I will probably play with the beta blocker, assuming that they are not bradycardic. That's another thing. And if they are normal tensive, then I will probably keep the dose of the beta blocker and the ACE as they are. Occasionally, let's say the patient is bradycardic, heart rate is in the 40s, and blood pressure is borderline. So then I'm afraid that if I go to 80 BID of Lasix, I may make them be too hypotensive. So in that scenario, I may cut the beta blocker transiently, yes, to facilitate diuresis. So if they were taking 100 of metoprolol, I would say just take 50 while we do this with the Lasix, knowing that we're going to go back. So you have to play with the blood pressure medications if it's needed. But that would be another reason. If somebody is wet, fluid overloaded, and hypotensive, it may become hard for you to manage them in the outpatient setting.
I think they would probably end up in that third bucket.
Yes, and you may need to, but you could try to talk, if they are bradycardic,
Right.
then you may hold the diuretic, now the beta blocker. Now, if they are tachycardic and they do need the beta blocker, you don't want to do that, so then you're finding yourself more in the third bucket,
Yeah.
as you say.
Is there for someone who has moderate hypertension in CHF, so say they're in the 150s to 160s range, what are the standard doses of metoprolol? Let's say they're going to be on metoprolol and lisinopril. What are the standard doses that you'd see on
So
them?
you should go to the highest tolerated dose. But again, you may want to start with metoprolol perhaps at 25 milligrams twice a day and see how they respond and escalate. The recommendation is that you escalate every 2 weeks.
Okay.
So if you start at 25 BID, then in 2 weeks you're looking for 50 BID, checking at heart rate and blood pressure, and then your goal should be 100 BID in the case of the metoprolol.
Is there a max dose that you start going, oh, wow, that's a lot of metoprolol?
100 BID is your max dose.
Okay.
You shouldn't be doing 200 BID. 100 BID is the max dose.
Okay.
And then with the lisinopril, usually lisinopril is a once-a-day medication, but in heart failure, oftentimes we will prescribe it twice a day.
Okay.
So, and you have a big range of dosages. You could start with 2.5 milligrams, or you could use 80 milligrams. So I would consider 20 milligrams or more as optimal in somebody with heart failure. So I may start with 2.5 if they are hypotensive, and then go to 5. Or I may do 2.5 twice a day, and then 5 twice a day, and then move to 10 twice a day. Or I may just do 20 once a day. It will depend upon how much of fluctuation in the blood pressure there is in those patients.
So what is how much of a benefit do you get from IV Lasix as opposed to PO Lasix?
Significant. Significant because when there is lower extremity edema, there is a good chance that there is bowel edema, and the absorption is diminished. The absorption of the pill is diminished. When you go IV, then you are already in the circulation and you are going straight to the kidneys. So I would say that if you have no edema, there is a difference. It's not the same to take, if you take 40 milligrams of Lasix as a tablet, I would say you get the same diuretic effect that 20 milligrams IV. But with the IV, you get it immediately. The other benefit is that the IV Lasix is a vasodilator. So in the acute setting, if somebody's in acute congestive heart failure, you're giving them a vasodilator that is decreasing the preload, and then they get a benefit from the IV because of that, which is harder to get with the pill since the effect is slower. So in my mind, 20 IV is equivalent to 40 PO. So when we give 40 IV, we're really equivalent to 80 PO. But I will tell you that it's much, much more potent.
Okay.
And we do like in the hospital setting to use drips, especially in acute systolic heart failure, because you keep the vasodilator effect, and then you have an ongoing persistent diuresis that you could titrate very easily. So IV has a substantial benefit over PO.
So let's say so we don't write on our 911 trucks anyway. We don't carry and won't be carrying Lasix. For our CHP trucks, I certainly have no problem if we think there's going to be benefit to putting IV Lasix back on. So let's say that my general rule of thumb that when I was a paramedic would be double the daily dose of Lasix for your IV dose. If they're already on, say they're on 40 BID or 80 BID, and they have a lot of peripheral edema, and for whatever reason you want to do IV Lasix, what would you typically start with?
So I usually will give them 40 and repeat to see the response. I don't see a great benefit of giving 100 of 20 of Lasix IV, because once the diuresis start, it won't stop, and then the electrolyte dearrangement may be bigger if you have given a larger bolus. So I may do 40 IV, I may do 80 IV very rarely, but I really don't do more than that. Okay. And you can also, at any time you could repeat. You wait for an hour. You should have, from the IV diuretics, you should have a good response by an hour. Okay. And then you see what kind of response you're having. If you're urinating more than 100 cc's an hour, then you don't need more.
Okay. So that's a good question. We go out and we see a patient and we decide that we need to do some IV Lasix. So we should probably be measuring their urine output.
That would be ideal, yes. So if you go there, you give, let's say, 40 milligrams of Lasix or 80 milligrams of Lasix, and you're going to stay in the house, and you wait for an hour and you measure whether urine output is in an hour. If it's less than 100 cc's, so you'll probably repeat the dose if it's needed. If it's more than 100 cc's per hour, then you can wait and see what.
And we should expect to see, in addition to the urine output, how quickly should we expect to see some change in symptoms? So if the thing we're trying to do is prevent them getting into that third bucket, so we want to prevent P&D or orthopnea, how quickly should we see the results?
Rather quickly. I would say, an hour and a half, patients should be substantially, better. Now, if somebody had a florid episode of pulmonary edema, which is acute, then, they may need to be seen in the emergency department. Now, if this is something that has progressed over the last few days, then you give in the Lasix and see if they feel much better in an hour is a reasonable alternative. But,
So that's a good marker there. So, as with many things, if they get into the condition very rapidly,
yes,
we probably need to get them out pretty rapidly.
Correct. We recently had a lovely patient of mine with advanced heart failure who had been in class 4 for the last 2 years, and we lost him in December, and he was doing fine, and I have seen him in early December. He was doing great, good dose of beta blocker, ACE inhibitors, and diuretics. And he was in the mall and developed an acute episode of shortness of breath, came here, was in pulmonary edema, and we did an echo, and he had a papillary muscle rupture. So he had a dilated cardiomyopathy. There was so much tension in the mitral valve apparatus that one of the chordates ruptured, and he had acute mitral regurgitation, for which he would need an open heart surgery, for which he was not a candidate. So he ended up going into hospice and, pass away. But the point being is you could have something that has come quickly. It may be a hypertensive. It could be an acute coronary syndrome. If it's an acute, abrupt onset of shortness of breath,
Third bucket.
the threshold to come would be higher.